Good afternoon, everyone, and welcome to the Support Hospital Opioid Use Disorder Treatment Shout Texas Echo. Please note that we are recording these sessions for future distribution. Please note that anything listed in the chat does not appear in the recording. My name is Shreya Prasanna, and I will be facilitating today's session. To help us with attendance, please enter your name, email, and affiliation into the chat function. To access the chat feature, please click on the speech bubble icon on the navigation bar at the bottom of your window. To all the BeWell Texas providers, please make sure you identify yourselves during the session, or if you're joining via phone, please email your phone number and a name to bewelltx@utisca.edu. Some housekeeping, please stay muted unless you're speaking. If you've joined by computer, your mute button is on the bottom left of your Zoom controls. If you're on the phone, just press *6. We encourage you all to unmute and speak, especially the discussion portion of our session. We want to hear from as many of you as possible, so please keep your comments brief to allow time for others to speak up. You can also share your comments and questions in the chat. Please note that no protected health information is allowed in either the chat or the discussion. If you would like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. You may need to click on More to find this menu. If you're having trouble accessing captions, please chat Echo IT. Towards the end of the session, the Shout Texas Echo team will send out an evaluation survey. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Our didactic today is on how to effectively influence change and will be presented by Dr. Chris Moriates. Following that, we will discuss a case presented by Samuel Burr. We will start with introductions, followed by didactics, BeWell program announcements, case presentation, and discussion. Thank you all for joining today's Echo. In the spirit of all teach and all learn, we encourage you all to share your experiences, questions, and insights in today's conversation. And with that, we will begin with some introductions. Chris.
Hey everyone, Dr. Chris Moriates. I'm a hospital medicine doc, and I am part of the Shout Texas team here at Dell Med at UT Austin.
Thank you so much. Blair.
Hi, everybody. I'm Blair Walker. I'm also with the hub team at Dell Medical School. I'm with psychiatry.
Thank you so much for joining us. Alana.
Hey there, everyone. Good afternoon. My name is Alana Bolton. I'm a program manager at Dell Medical School and the director of Shout Texas. Thank you so much for being here this afternoon.
Thank you. And Andrea Hebler.
Hello, everyone. My name is Andrea Hebler, and I am the program coordinator for CSTAT for the ECHO series, and I'm happy to be here.
Thank you so much for joining us. And with that, we will move on. Oh, sorry, Sam. There you are. Can you introduce yourself, please?
Sure. I'm Sam Burr. I'm a third-year medical student at Dell Medical School.
Thank you so much for joining us. And now we'll move on to our didactics. Chris, you can take it away.
Great. Thanks, everybody. Let me go ahead and get my screen pulled up for you. All right. And we are going to talk today about how to effectively influence change using a framework called Leading from Where You Stand that I share with students and faculty and residents and basically anybody that wants to listen about this idea of how can we effectively lead no matter where we may stand within the position. So how can you influence even if you lack authority or power? This will be interactive. So I'm hoping that you guys will, you can use the chat box. I've got my eye on the chat box, and you also can feel free, and I encourage you to please unmute and speak up as we think about how to do this. So first, here are learning objectives. We're going to demonstrate examples of effective peer leadership and the importance of leading from where you stand, describe the role of power and influence in leading change. We're going to analyze the use of persuasion and influence to achieve your objective, especially when you lack authority. I do not have any disclosures relevant to this presentation. I want you all to spend just a second and think about a time you were able to influence a change. This doesn't even have to be medicine related. This could be whatever it is in your life sometime. And I know a lot of you are like eating lunch and half paying attention or whatever right now, but I really want you to do this. Take a second, think, when have you influenced a change, big or small, and get that example in your mind. I won't make you speak up yet. Okay. You, like me, have probably heard about and seen lots of different frameworks or definitions for leadership. And this is one that I was taught a while ago now, but has really stuck with me. And it is that leadership is vision plus task plus relationships. The first thing I want you to notice about this definition is nowhere in it is title or position. When people think about leadership, oftentimes folks think about a title, a leadership position, and they think that that's the way to create change, right? One day when I'm the attending, one day when I'm the chief, when I'm the chair, when I'm the dean, the CMO, it kind of never ends. There's always somewhere else to get to. You think then I will be able to get folks to do what I want. And in some ways that's true. Certainly with titles and positions, you have opportunity to drive behavior. But I'll tell you that a title and a position is neither necessary nor sufficient to be a leader. I think in order to be a leader, what you have to have is one, a vision of something that we're trying to achieve. So a vision of something better, you know, a vision where people admitted to the hospital with opiate use disorder actually get treated for their opiate use disorder. It doesn't have to be grandiose, but we have a vision. Now, certainly in Austin and lots of places, we talk a lot about visionary leaders, right? Visionary leaders who have visions about where we're going to go or what we're going to achieve. And I want to tell you that if all you have are visions of things, that's not leadership, that's psychosis, right? If you have visions, that's psychosis. You have to have visions plus a task. So a responsibility, an accountability, a plan about how do we actually achieve this vision that you have. The plan may or may not work, but I'm accountable to trying to figure out how do we get to this better place? How do we get to a world where people are treated for opiate use disorder during hospitalization? And then the last component are relationships, right? To be a leader, you have to draw on your relationships in order to bring people along to change behaviors. So I would say that whether you are our medical student, Sam, or a CMO or whomever might be on this call, we all, I would propose, have the components that it takes to lead from where we stand. So I want us to think a minute about power and influence. These are how we generally get people to change their behaviors, is to use power and influence. And there are two sources of power. The first is indeed positional power. So as we talked about, I mean, if you have a position of power, that means you have the power to have authority, to reward, to discipline. Any of us that are parents, this comes with the territory, right? We have some positional power, and we can change people's behaviors. But as we all know, there's a lot of limits to that. People resist and rebel positional power in both subtle and non-subtle ways. So even though we think that this is the way to actually drive change, people oftentimes resist if you're flexing positional power to make that change. So the other is personal power. I think this kind of like social capital, right? Using our expertise, our information, our goodwill. I listen to Dr. Walker and I change my behavior based on what Dr. Walker recommends to me, not because she has positional power over me, but she has personal power. She's got expertise that I don't have. She has information I don't have, and we've developed goodwill. At least I hope. I've got goodwill for her. So I trust her, I know her, I respect her. And that gives her power. But the other way we change people's behavior is through using influence. I just quickly want to say that the way we're going to describe influence here is it's an action. It's moving another person toward making a choice or commitment that supports our goal. I particularly discuss this because when I talk to medical students, of course, They live in a world of influencers. Like influence is something that you have, and that's fine. But influence is not something we have. Influence is something we do. So any of us can influence as a verb. And what we're talking about is just moving someone towards making a choice or commitment that supports their goal. So now I want you to think about it. In fact, if you've got a piece of paper right in front of you, so I know many of you do, or something that you can jot on, quickly write down an area where you want to influence others, something that you want to do. We're going to hear today from Sam about an area where he wants to influence others and wants to start a program and lead. But I hope that most of you on the call are on the call because you're thinking about how you want to influence. Maybe you want to get the hospitalist in your group to prescribe buprenorphine. Maybe you want to get your emergency department to do it. I don't know, maybe you want to convince your significant other to go see Oppenheimer instead of Barbie. I don't care what it is, but you want to influence someone. I want it to be real. Does anybody want to share? You can share in the chat box, or you can unmute and share an example.
Boo, it's Blair. We definitely have goodwill, but Barbie over Oppenheimer. That's my next plan.
Yeah. I got Oppenheimer tickets, but not for like 2 weeks. It's like sold out for a while. Right on. One more, anybody? Come on. I teach on Zoom a lot these days. I've gotten very comfortable with silence and waiting you out.
Okay, I'll do a real one then, since no one's talking. And even though I'm driving, I am about to do like half-time work, maybe temporarily, maybe forever, at a different hospital who doesn't at all have as much comfort level or expertise with buprenorphine. And so I have a new, I have a new vision. And was just thinking and being inspired by you, actually. Thank you so much for this, of how are we going to enact that and just sort of invite the doctors over there who've actually had the power at the hospital tell them, you have to do this, do a B team like we did, and who's going to be champions. And the response has been literally crickets chirping for months. Yeah. Exactly as you described. And I thought, but now there's some, folks who've done it a lot more. And I was thinking, I'm going to just invite people to no, we're here to guide and help if you want to start to get after this and get comfortable with this. And I'll bet you we'll have some takers. So I was enacting my plan for how to be gently inviting rather than the authoritarian, we're doing this. But also being cautious to not overextend myself at the same time.
Great example, Blair. And that's where I am today, by the way, at that hospital that you speak of. But I don't come here very often either. And I'm really glad that you're going to do that. We are going to, hopefully, the things I'll share over the next, 5 to 10 minutes here will help think through how to approach that well. So, yeah, thank you, Kristen. All right, so we're going to move on here. So there are 4 key elements to persuade and influence effectively. These come from a Harvard Business Review article that was published a long time ago, actually, by Professor Jay Conger, called The Necessary Art of Persuasion. And I want to pause for 1 second, because if you, like me, you might get this kind of feeling when you hear the words persuade and influence, right? This kind of icky feeling maybe in your stomach. And I just want to be clear, I'm not here to get us to be slick or get us to try to pull one over on folks or be a used car salesman. In fact, the point of this is that actually the things we're going to talk about, these key elements, we do all the time. And the question is, are we doing it intentionally or not? Do we recognize what we're doing, and are we trying to do it on purpose, or are we just doing it without recognizing it? So I think of sometimes it's like a sword I might have. And it's like, do I know I have this sword and I'm going to swing it intentionally to hit my target? Or am I almost not even aware it's there and I'm just swinging it around? And sometimes I end up hitting my target and sometimes I make a mess. And so I want us to just be aware it's there and try to use it effectively. So the 4 elements that we'll go over in turn are establishing credibility. How do we do that? Framing for the common ground, providing evidence, and being aware and matching the emotional energy and receptivity of the audience. Okay, so those are the 4 elements. We'll review each with quick examples. So the first is establishing credibility. Whenever we ask anybody to do anything, they're going to immediately think about, can we trust this person's perspective and opinion? They may do that subconsciously or consciously, but that's the question they ask themselves. Why should I listen to you? And usually that can only be established over time. It's only established because it's based on consistent outcomes and experiences. I listen to you because I know that, I know you over time and I know your outcomes. I know that you do good work. I know that you've got this expertise or this experience. But sometimes this is our area of weakness. Sometimes we don't have the expertise. We can't walk into the room and say, I've been running a B team for a few years now, and I know how to start one. So if this is your area of weakness, what can you do? If you're Sam, who's an amazing person and like getting really interested in this, but not yet have the credentials to say I'm an expert, what do you do to establish credibility? So in the interest of time, I want you to think about these things, but in the interest of time, I'm going to keep going. So the things that you can do are you can learn more through formal or informal education. And you have to ask yourself about what do I need to do this? Do I have to go, if I'm going to start a B team, like, did I have to go and become an addiction medicine trained physician? Like, do I have to go do an addiction medicine fellowship to get any sort of credibility? Or can I do more informal education and develop, and that really depends on the setting and the situation. Sometimes you do need like formal training to have the credibility to do what you want to do. The second is to tap experts within the organization to advocate your position because their credibility becomes a substitute for your own. So you really want to set up, you want to tap those experts to advocate. You don't have to have the credibility or the expertise, but if you bring along, Sam, if you bring along John Weems' expertise and credibility extends to you now in your project. You want to use outside source of information to support your position. It's not just my idea. It's not my crazy idea. We should be doing this. We should be doing motivational interviewing in the emergency department or whatever it might be. So we want to not, point to others or other source of information that support our proposal. And then the last is we want to build a track record of success so we can launch pilot projects that demonstrate on a small scale our expertise and value of our ideas. When I was a resident, I started a cost awareness curriculum at UCSF back in 2010. And I started by saying like, hey, first I brought chief resident quality and safety and a faculty member who wanted to support me. They came with me, so their expertise extended to mine. I was learning as much as I could through informal education. I decided I didn't need formal education to do this at that time. I was pointing to the New England Journal article by Molly Cook saying that we should talk about cost of medical education, even though we had not yet. It's not my crazy idea. It's Dr. Cook's idea in the New England Journal. And then I said, let me try it once. We'll collect evals. We'll see how it goes. And then once it went once, said, okay, let's try this again. And eventually built that track record over time to allow us to build this out into a monthly conference. So the other example I point to, this is a colleague of mine, Mike Broad. I don't know if he knows that I do this. I should tell him. But Mike Broad joined our hospice group in the summer of 2019. He was a chief resident for University of Washington, Seattle. Really smart, brilliant guy, but first year faculty member, joins our hospice group, is planning to do all this therapeutic informatics like design stuff. And then COVID hits. Mike Broad is no COVID expert. There were no COVID experts in March 2020, but Mike took it upon himself to learn as much as he could. You quickly learned that you could trust that Mike was reading the evidence, digging in as much as he could. And then he brought together experts. He brought together infectious disease and critical care and pharmacy and everybody, palliative care, and they would review the evidence in real time that week and they'd make recommendations. And Mike Broad quickly became an expert, a recognized expert in this space because he had the credibility, the buy-in of this group of folks. He was reliable. He built a track record. And now he's invited nationally to speak about COVID. And so he did that by establishing his credibility in those ways, by drawing on relationships. The second key element is to frame for common ground. This means illuminating the advantages for others. And that means we have to understand our audience. So when the B team was starting, I think that actually members of the B team ended up being really good at this. That when Nick Christian, the resident who really helped inspire the starting of the B team, when he would get up and speak to the other residents or to the hospitalists, he would tell the personal story of his friend who died from an opiate overdose. And he would explain then about how effective buprenorphine was and why he had like a personal mission to improve the care for these patients that we were taking care of in the hospital. And that was huge. And then he brought the evidence and tied that in. Now, when we went to speak to the C-suite, when Rich Botner went to speak to our CMO, CFO, even though their mission is the same, even though we have the same mission, the plaque on the wall that says that's what we're about, they led with like, hey, the evidence shows this decreases readmissions. The evidence shows that this is going to be cost effective, and we can actually run this without any extra cost. And they led with that. And by the way, it's the right thing to do. And here's a patient story. But by leading differently, I think that was really important. If Nick got up in front of the residents or the hospitals and was like, hey guys, buprenorphine decreases readmissions, the hospitals like care about that, but it'll also be like, okay, dude, are you shilling now for the C-suite? Like, what's the deal? But that's not what he did. He led with why this was important to him and really captured us wanting to join and lead with him. The third element, provide evidence. We oftentimes think because we're speaking to physicians or business people or scientists, that evidence really means hard, cold data. And the fact is that while that's somewhat true, all of us are human beings, and human beings do not respond to cold, hard data. None of us do, actually. None of us do. We don't change our behaviors. If you want to look back, read about hand washing for 100 years, like didn't really change our behaviors, even though we had the data. You have to supplement the data with examples, stories, metaphors, analogies. So those patient stories, those patient cases that make it come alive, and then tie it with the data, with the evidence. So anybody who reads Atul Gawande, he's a master at this, right? Atul Gawande tells you about McAllen and then tells you why it's not about McAllen, or tells you about this patient who was harmed by overuse and then tells you the scope. So really important. When we had a resident of ours who was going to start a penicillin allergy delabeling project, she was practicing her noon conference that she was going to give to the residents right before, and she did a great job talking about why this was IDSA guidelines and why it was important, why we should do it, and blah, 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 blah. And at the end of it, I was like, Kelly, that's great. You do a great job. It's convincing, but like, why are you doing this? I know you want to go to ID fellowship. Why are you doing this? And she said a great story about a patient of hers who had a penicillin allergy, who got second-line antibiotics, had a bad outcome. And she looked into it and realized that that was common. And I said, lead with that. And leading with that story, I think was really helpful. Okay, the fourth element, I realize we're running short in time. The fourth element is to match the emotional energy of the room. And so this means, I kind of think of this as like, you don't want to give the same speech or come off the same way at a wedding as you would at a funeral, right? Because if you do, people are like, what is up with this person? So similarly, like you got to understand the emotional energy. If I went into the ICU when we were really in the shit in the middle of summer 2021, when we have like FEMA nurses taking care of COVID patients, and I'm like, guys, I want to do this, allergy delabeling project and like come with all this energy, they would be like, can you understand what's going on around here? Do you see the temperature of the room? And so you want to make sure that you match the emotional energy about what's going on. And so sometimes that means we come very serious and provide the data very, in a very calm and sober manner. And sometimes it means we come and we try to persuade and bring, a different type of energy. So let me end with where this goes wrong, and then we will move to our case and our announcements in our case. There are a couple common pitfalls. The first is doing the hard sell up front. When we do the hard sell up front, people naturally resist. So, Blair, if you come in here and you tell the hospitalist here at this hospital, like, you must do this. Like, what you're doing is wrong. It's not standard of care. We did, like, basically you hard sell and you get, and like, then I think most people like immediately just kind of resist that. They have a natural reaction to match that energy. So if you push, they block. And so we don't want to do the hard sell up front. Usually the reason we do the hard sell up front is because we think it's a one-shot effort. And none of these projects really are a one-shot effort. None of the things that we want to achieve can really only be done in one conversation or one meeting. It's going to take more than that. So again, I think of this like, look, I haven't dated now in many, many years, but I assume this hasn't totally changed. This is like, if you're on a first date, you're not there to try to convince them that they should marry you. You're there to convince them about a second date. So you want to start the conversation. When you meet the hospice, you don't need to convince them to go all in on starting a program tomorrow, but you want to get a second date. And so that's the idea. The third is not being willing to compromise. So all or none, that's pretty self-explanatory, but we get this wrong all the time. And the last is thinking that only great arguments will work. It turns out that's not the case. That sometimes we've got a COVID pandemic going on and too bad. We're just not going to be able to do a B team today. It's not happening. Or sometimes the CMO is just really mad at the chair of medicine and is not going to support anything from the chair of medicine. Too bad. Nothing you can do about it, out of your control. And you may not even know that. And the other thing is, it's not just about great arguments. It's about our relationships. It's about our track record. It's about the goodwill, the social capital we built up. That's how we get people to change. So no matter where you stand, there are small things we can do that can help drive those changes and influence people. And the way we think about approaching it can be really helpful and transformative. And so I want to thank you. I want to ask for any questions, and then we'll do announcements and a case. And today, as I alluded to a lot here, we've got a very different type of case, and that we're going to do more like a systems case study and give advice about how to implement a program, which I think follows really well from our discussion today, rather than a specific patient case. And I'm really hoping that everybody will be able to engage and dig in and give some advice on that. So thank you very much. I appreciate your time and welcome any questions.
Thank you so much, Chris. That was a wonderful session and a lot of thinking and reflections there. I'm going to open up the floor for any questions for Chris, or maybe any thoughts about the presentation. And we're all used to the silence, so we can wait.
Bueller. It's Blair. I'm finally, apologies for being driving earlier, but thank you so much for that. I've never heard that talk and it was fantastic. I'm feeling inspired. I don't know what other people are thinking, but that was really helpful. And I like the idea of sort of really being deliberate and formalizing, the plan so that you can enact change more effectively. So thank you.
Thank you, Blair. No, thanks for the kudos in the chat. I appreciate it.
Mm-hmm.
I give a 90-minute version of this for the med students. So you guys got the 22-minute, but.
Well, thank you so much. I mean, it's hard to condense it and give us the short version, but thank you. So I guess we'll move on to announcements, but feel free to pop in any comments or ideas on the chat. Thank you, Andrea, for sharing. The Center for Substance Use Training and Telementoring provides high-quality education in best practices for responding to substance use. CSTAT can help enhance professional knowledge and self-efficacy to screen, treat, and make referrals to people with substance use disorders. To learn more, please visit us at cstat.utisca.edu. Next slide. To claim your CME credits, please text the code attend 100093880 to the phone number on your screen by midnight today. You need to text by midnight today to receive the CME credits. Next slide. Please join us for our next session on Thursday, August 17th. We will be discussing treating opioid use disorders in the context of fentanyl use. This will be a great session. Please do join us. And with that, we will move on to our case. Andrea, if you could please share the case. And Sam, if you could just summarize and the major details of the case.
Yeah, absolutely.
Thank you.
Thanks everyone for your time. It's good to be here. I'm grateful. I think the big overarching questions that I have sort of associated with this project, which I'll get into and kind of describe some of the context and motivation for, are how can medical students be engaged in the delivery or in being trained to deliver or administer screening, brief intervention, and referral to treatment, just sort of an efficient modality grounded in motivational interviewing principles to patients who are either presenting to the emergency department with pathology that is directly related to a substance use disorder, or who have an incidental substance use disorder in addition to the pathology they're presenting with, or just have risky substance use. Is it possible to focus on through this project tracking outcomes and how well we're training medical students in administering ESPERT, while also tracking patient outcomes, i.e. are the is the ESPERT that's administered by medical students in the ED producing meaningful sort of outcomes for patients, in addition to our medical students feeling comfortable with it, and are they competent in performing it, or is that too challenging or too hard? And then finally, just hopefully we can have a discussion about just the fact that a project like this, even if we got a bunch of medical students and they were really great at performing ESPERT, and we were able to utilize it a lot in the ED, if we have a lot of patients who don't have insurance or don't have some sort of coverage that will allow them to engage in formal outpatient or inpatient services for their substance use disorder, does the project kind of fall short as a result of that? So there's right now not a whole lot of inpatient, at least, resources for folks who are uninsured, who have a substance use disorder. And then would a project like this that sort of uncovered that lead to a sort of a bigger conversation about what can be done about that. So with regards to the situation and kind of the motivation behind this project, so just to Chris's point, my sort of personal bend with regards to this project is I 8 or 9 years ago, sort of through adolescence and kind of early adulthood, had developed a substance use disorder that eventually sort of crescendoed and resulted in my having to go to inpatient treatment and then live in sober living. And that experience, I can honestly say, probably saved my life. I would not be, certainly wouldn't be a medical student, certainly wouldn't be here talking to everyone about this project if I didn't, have the benefit of that intervention. So this project is, the part of the motivation is wanting to at least provide some similar opportunity for folks who are struggling similarly with a substance use disorder to get a chance to escape that and to do something meaningful with their lives in the same way that I was able to do, or at least I'm trying to do. So while I was on my ED rotation, that's a fairly open-ended rotation. We sort of on our own time go and see patients. We present to residents and or attendings. They give us feedback. We rinse, repeat. We probably do that 3 or 4 times per shift. We get about 16 shifts plus minus 2. So during that rotation, just anecdotally, a large percentage, or at least a significant percentage of the patients who we would go and interact with or would see on the tracking list were presenting to the ED with incidentally identified or at least historically known to have substance use disorders, or were presenting for pathology related to a substance use disorder, whether that was experiencing withdrawal, experiencing some sort of infectious complication from IV drug use, et cetera. So the sort of what that resulted in really was in the ED, if someone was asked or at least pre-screened within just sort of the history taking process, taking a social history, which often includes, do you use substances, do you use alcohol? If that was, a yes, and it was just super blatant that it was involved in their presenting pathology, they may be offered to talk to a social worker who may provide resources for that patient. And that was kind of the extent of the sort of referral process, at least in the ED. And that wasn't, because folks in the ED who are treating patients don't care or are overlooking that. It's mostly a bandwidth issue. So physicians, nurses, social workers have a million things that they're already doing. It's difficult to spend 15, 20 minutes with a patient going through a screening, brief intervention, and referral to treatment process. Medical students, on the other hand, have bandwidth. We have lots of time in the emergency department to potentially perform something like this. And just as an aside, ESPERT is vetted as a sort of an efficacious modality, in clinical settings to connect folks with substance use disorders to treatments. A couple of studies that I looked at that were big kind of motivators for this project, in addition, was one that was performed by medical students over the course of 6 weeks, which was able to produce meaningful outcomes in a handful of patients without causing harm. So I think that was a big component there. And then another, which actually hired 3 substance use disorder navigators, which sort of screened indiscriminately everyone who came into the ED and ultimately referred thousands of patients to residential treatment. And lots went and benefited from that. So the plan essentially for sort of this project is can we do something similar to the former sort of study / project that I mentioned? Can we train medical students as part of their orientation to the emergency department rotation to administer screening, brief intervention, and referral to treatment in the ED with at least one patient? And so, the benefits of that are twofold. One, the one that I mentioned, basically, at least, having a conversation with a patient that is grounded in motivational interviewing principles, that's patient-centered, to at least help them develop some self-awareness or increase their motivation to engage in some form of behavior change as it pertains to their substance use, and also to improve medical student competency and comfortability in performing something like this, such that when they're residents, when they're physicians, even if they're on their other rotations like internal medicine, for example, they can use this tool in the event that it is warranted in a setting. And to be honest, everyone should, I think, probably get screened, if not pre-screened. I think as we sort of pivot from more paternalistic care to patient-centered care, I think that this tool is going to become more and more valuable for students, residents, physicians. So in terms of logistics, the idea is to, during orientation, have a sort of training module that's administered by Dr. Berg and Dr. Velasquez, who are very sort of notable members who are professors at the School of Social Work and Psychology, respectively, and who are trained practitioners in training folks how to perform motivational interviewing and ESPERT. And they're sort of fairly purists about how it's how people are trained in being able to perform that, and are very invested in making sure that those who they do train are actually good at then sort of going on to perform it. So we'll do a training session that will include a pre-assessment survey, a pre-comfortability survey, which will sort of identify where students are at this point. Students get about 3 hours during their first and second year curriculum total in motivational interviewing training. So they may have some background, but certainly not enough to, I think, go out and perform this without additional sort of supplemental training with Dr. Berg and Velasquez. After that, what we've sort of landed on at this point is using Be Well funds. So Dr. Berg and Dr. Velasquez have access to the sort of Be Well grant to fund an OSCE that could range between 2 and 4 hours for the students. We were wondering whether we should put that prior to students going off into the ED and attempting ESPERT, or toward the end of the rotation. I think it makes the most sense to do it prior to their entering into the ED, so they get more training and they get more formative feedback And Dr. Berg and Dr. Velasquez get to sort of see them in action and give them their blessing prior to their going into the ED to make sure that what they're doing is correct. Once students are in the ED, after they've performed their OSCE, they'll do the SBIRT. And in the event that a patient qualifies just through the screening for a brief intervention, the brief intervention will be performed, and then a referral to case management social work will be made. So a consult will be made by that student to perform a warm handoff to the patient. That'll include sort of context, their motivation level, their MRN, insurance status, et cetera, to sort of tailor the referral that's made, and anything else that the social worker needs to sort of proceed with offering resources. They'll evaluate themselves using a self-evaluation assessment. It's sort of a CEX. It's used by other sort of pre-existing SBIRT curricula that are used to train residents. They'll bring that to a sort of debrief with Dr. Velasquez and Berg, discuss that, what went well, what didn't go well. And then toward the end or at the end of the rotation, they'll take another comfortability survey, post-assessment, and the OSCE post-assessment comfortability survey and self-assessment will all serve as sort of data points to determine whether we're effectively training medical students to perform this in the ED. With regard to patient outcomes, and this is one of the overarching questions that we had, do we want to track that? Is it possible to track it? During the motivational interview, or at least the brief intervention itself, we'd have to determine what or quantify their use at that time. We can rely on the audit and DAS scores that will be used during the screening. Like I said, their motivation level, and then use that as a baseline. And then after 1 month, do a 1 month sort of follow-up call with those patients, if they were referred to a social worker, or even if they weren't. Re-administer DAS to audit potentially, or just quantify what their use is at that point. Again, this is just going to be self-report data. Did they engage with the resources that they were referred to? If so, great, what was helpful? If not, what happened? So sort of a needs assessment component there. And then sort of where their motivation level is at that point. So that'll sort of serve as the sort of pre and post kind of data points that we may be able to use to sort of assess whether this is an intervention that's helping people. But at the very least, I think it may be enough to just say that this is something that's, one, not doing any harm, and is shoring up students' abilities to perform an important intervention like this. So potential, I think, issues with this project is, I think, one, it may be really challenging to follow up with folks at 1 month. This is something, at least when I discussed with interested parties last week, it was noted as something that has been difficult in similar projects, I suppose, in the past. I think measuring medical student motivational interviewing competency or SBIRT competency, would love some feedback on how that's, I think, structured and planned at this point. Hopefully students are invested and want to do this. I think that's another potential barrier. My hopeful plan is to sort of get with the Dell admin and at least get in front of the second year medical students to discuss this project with them. I think as much as this is for folks in the ED, this is for medical students. I think they're a major stakeholder here. And if this is something that they just cannot get on board with or feel is adding too much to their sort of respective bandwidth and just don't want to do it, then I think that that's worth noting and at least factoring into sort of subsequent decision-making. Although I will say that I think most of this is just formative and won't, impact grades and shouldn't be super cumbersome, just given that it's a mostly open rotation.
Hey, Sam, just drawing attention to time, just because I think,
oh, sorry. Yeah,
I think maybe opening it up for some like input from the group, and I wonder, you've got a couple of different questions, and I think there's a lot of ways we could take this, but just thinking about the experience from the group, It sounds like some of the areas where input would be helpful would be people's experience around maybe if there's any expert training, MI training, like resources, tools, experience that people have used. And then the outcome measurement part, because I know a lot of folks are doing some, projects and like, how have they gone about trying to follow up what happens to patients? Would that be a fair place to start?
Absolutely. Yeah. So sorry. I know I
Okay.
can get a little.
No. I appreciate, thank you for sharing all this, and it's awesome that you're doing it. So I guess from the group, anything that, feel free to comment or provide feedback on any piece of what Samuel presented, but I would particularly ask for examples that you might have from your own work around the areas I just mentioned. Megan, please.
Mhm.
Hey guys. Sorry, I was eating my lunch. You said that you guys are probably eating your lunch, and I was like, I don't even know. But in regards to feedback, I work in a group where we are constantly calling folks who have come to us for help at 30 days, 60 days, 90 days to see how they're doing. And it is really hard because sometimes their phone number changes. So getting the patient feedback might be hard. What might be more useful is if you do like a before and an after, like stigma quiz with your medical students. And you could, that way you've got like a before and after group who you can actually get answers from. And that might, because I think that's one of the main things that you're driving, is that you're kind of teaching early doctors how later to be able to approach these types of topics with a bit more compassion and be able to get people connected. So I think maybe instead of trying to focus on feedback from the patients, maybe try and get feedback just from the students on how their perspective on substance use disorder and treatment and connecting folks with that has changed.
Awesome. Yeah. Thank you. Yeah, that's something that we definitely are also looking at in that sort of comfortability survey, is also just not only do you feel okay with it, but do you think it's useful? Do you think it's worthwhile doing sort of moving forward? And I love the stigma part too. I think that's a huge component to it. So thank you, Megan.
Any other suggestions or questions from our learning community here if you have implemented similar programs?
I wanted to add one thing, Sam. I had a couple expert student training grants, and something that can help in terms of the time limitations is using simulations instead of OSCEs. OSCEs are great too, obviously, but if you can do a quick online simulation that's 10-15 minutes that students can engage in quickly, it gives them that other opportunity to practice the expert and MI skills. And I can point you to some that are in the public domain. I might have to dig around and look them up, but we can get them to you. And then the other piece I was thinking is in terms of buy-in, just making sure, I'm sure it's probably part of the instruction they're getting, but just making sure that they understand that the expert screening is part of the national recommendations from the Preventative Services Task Force, and just helping them understand that that would be the national and international guidelines and why it's so important. Because nobody really wants to be out of, adherence to the guidelines, right, and best practice.
Absolutely. Yeah. Thank you, Adrian. Yeah, I don't anticipate getting a whole lot of resistance from at least Dell medical students. I know, at least from the ones that I've spoken to, this is something that I think a lot of them are aligned with. And I think also watching it in practice is so inspiring. I think, when I went and watched Dr. Weems do it, it was phenomenal. But yeah, I think an online simulation too would be really, really wonderful, and hopefully maybe even more so efficient and more palatable. So.
I think knowing the prevalence rates too, and again, I'm sure it's part of the instruction, but I have heard students say things like, well, that's not really the patients I'm working with, or I don't really see that very much. And then when you let people know what they should really expect in terms of the proportion of the population that say is engaging in risky drinking, then they get a clearer sense of like, oh yeah, this is a quarter to a third of the patients that I'm going to see. So.
I'll share from a med ed perspective when you're thinking about. So this is interesting in a way, actually, because whether it's, and you don't have to draw distinct boundaries on it, but whether it's a, curricular medical education project, or it's like a quality improvement project. And the reason that is somewhat relevant is because the way you frame it will help you think about what the intended outcomes are, I think. So in medical education programs, there's sort of this pyramid of outcomes. So the first level is just like satisfaction, right? And a lot of curricula, that's how it gets, you fill out an eval, you say, did you like it? And that's like the end all of like the evaluation, which is like fine, but not that important. So satisfaction is the kind of base, or back maybe even below that, it's really just engagement. Did people actually do it? Like, did they come to class, or did they do the sessions? Did they whatever? So engagement, then satisfaction. Then you've got knowledge. Did they actually change their knowledge? And you can test that pretty easily. Before they started this, did they know how to do motivational interviewing, or did they know treatments for AUD? And then after knowledge is attitudes. So that gets to, I think it was Megan was talking about around like stigma and, somewhat knowledge, but mostly attitudes. Like, did it change their attitudes? And then next would be behaviors. Did they actually do something different? And you're actually getting all the way there, because you're going to have them do motivational interviewing, right? So you're going to teach them how, you're going to then have them do it. And then the tip that like almost nobody ever achieves in educational interventions is to measure actual change in outcomes, like patient outcomes. So if you can measure a change in patient outcomes, that is like, the highest level of an educational curricula. That all said, well, that's ideal. I think that is a tough charge. I think if you could measure everything else up on the pyramid for the type of thing you want to do, and since it's aimed at medical students, I think that is a tall enough order. And I would suggest that evaluating the outcomes is something that, instead of you really working on figuring out how you're going to do that and the infrastructure and all that, I would actually spend more effort on trying to convince somebody else to do that. Meaning, like, can you get the Shout Texas team jazzed enough about it that we're going to put resources into measuring the outcomes? I'm glad Alana's not on camera right now. Looking at me. Can you get, or can you get the Department of Medicine, or can you get, but the idea behind like, the evaluation can actually be separate, and you're usually, that's where like resources, that's usually like grants and stuff, right? Like, we couldn't really measure our B team follow-up rate super well until we had external funding to do it. So just to share, that's kind of how I think about it. And it's not to discourage you from measuring that like top level, but it's just, that is a lot. Like, I think that would take all the effort, and I would probably spend my effort on changing the hearts and minds of the medical students at this point.
Got it. That makes a lot of sense. Well, thanks everyone so much for the feedback, and I'll definitely sort of take it and run with it. I think that's a great idea. I think hopefully we can have more conversations about whether we can have at least some process, even if it isn't tracked, to sort of check and see if things are working out for the patients that we try to intervene on.
Sam, are you having trouble recruiting students? Are you in the process of even doing that yet, or you're just anticipating?
A lot of the discussions I've had thus far are with the ED clerkship itself, with the ED, with folks helping me data collection in Berg and Velasquez and social work, but I haven't actually gotten in front of the medical students. So they are not as of yet aware that this is like something we're trying to do.
Okay. Cool.
So
I know you get a fair bit of like MI training, but like they're getting extra training and doing something extra. And so the other thing I was thinking is, how do you incentivize that or reward it? And would some kind of, certificate, which is easy to just make, we complete trainings. Here's some Texas Health and Human Services, something I had to do for, whatever CME, but some sort of certificate, but also like, it's sort of like an official thing that you could like add to your CV. It adds a little expertise, as we were talking about earlier, like, you've done expert training and then you did this session, you could kind of call it something so that it can be something that everyone could add to their CV, because it's special and something different that not all medical students necessarily get during their training. So I wonder if something like that could help people just be interested in it. It's not like going to be a major part of it, but it's sort of a little nod of like, this is an extra training that you're now like, I don't know if there's any official certification, Adrian, or like anybody else, like is there a way to parlay that? I mean, Lloyd Berg, who you keep on mentioning, is who taught me motivational reviewing. He's like our guru, and he does stuff, you know, nationally. And is there something out there he can help you with that too? I also wonder if you have trouble with just the Dell Med students. We also have IBH scholars and PhD students and stuff like that who could get involved, and also because they're going to be sort of ahead of the medical students in some of these things already, naturally being PhD students, but you'll have other students as well, and they could sort of model with each other and stuff too. So it might be able to swell your numbers if you needed more numbers later. And Dr. Berg can help you with that because he's involved with that. So that's another thing I would think about.
Yeah, that makes total sense. And actually, you know, something that I talked to with Dr. Coyne, who's the ED clerkship director, you know, in terms of incentivizing this process, is he actually brought up, he was like, you know, we could try to make it sort of part of getting honors for the, the rotation, which I feel like that is, it transitions a little bit from it being more of a carrot to a stick. But I thought, you know, maybe it's something that is like factored into sort of their, you know, end of the rotation, you know, evaluation. But I think that if it's like, you know, CME, if there's some sort of certification, I think that, you know, all of us medical students love that. So, but yeah, I appreciate the feedback. That's great.
That's awesome. Thank you so much. This was a wonderful discussion. Chris, if you could please summarize some of the key points for Sam here.
Sure. Yeah. So just, you know, over the last hour, we talked about leading from where you stand and how to use some specific tactics to influence folks to change behavior. And then we had this great example of Sam leading from where he stands as a medical student to start a program to both teach his colleagues and change their attitudes and behaviors, and change their practices in service of treating patients in a way that he sees a gap. So specifically getting students to perform ESPERT in the emergency department for patients, which I think is really inspiring and helpful. And hopefully heard some feedback about how others have thought about doing ESPERT training and about how to think about measuring the outcomes, and how to also convince students through giving them some sort of credentialing or other, you know, thing that can go on their CV. So thank you everybody for joining us today and thinking through how to apply these lessons in our lives.
Thank you so much, Chris, and thank you all for joining today's session. As a reminder, to earn CE credits, please text the activity code 10093880 to 844-502-1338 by midnight today. We also request you to complete the post-session survey using the link in the chat. The survey link will be open for 1 week. If you would like to present a case, please email bwelltx@utisca.edu. We'll look forward to seeing you at our next session on Thursday, August 17th. Have a wonderful rest of your day and enjoy the summer. Thank you. Bye-bye.